This week on the BackTable podcast.
It's pretty amazing when you see like a hypotensive crashing bleeder and boom, you embolize, and literally by the time they're getting out of the room, they've been stabilized. There's something great about that.
It's funny because we'll get the coils. You see the active bleed, you put the coils in and you occlude it. And I'm sure you've seen it where it's just the tachycardia stops and it's like almost instant. It's deceiving how quickly it is.
Yeah, it's pretty addictive. Hello, everyone, and welcome to the BackTable podcast, your source for all things endovascular and more. You can find all previous episodes on any platform or our website, backtable.com. You can also follow us on Twitter, Instagram, or LinkedIn, and keep up with the latest updates and give us feedback through comments. Today's BackTable podcast is sponsored by Boston Scientific Interventional Oncology and Embolization Division. Boston Scientific is an international provider of medical devices for the interventional radiologist. Boston Scientific's goal is to become interventional radiology's leading partner by enabling and developing minimally invasive procedures for the detection, diagnosis, treatment, and palliation of cancer and other non-cancer diseases. Boston Scientific has recently launched the TruSelect 2 French microcatheter. This selective microcatheter is specifically designed to access small and tortuous peripheral vasculature to deliver all 018 coils, embolics up to 700 microns, and Y90 products including TheraSphere. It also has the first ever 175 centimeter length microcatheter, which is ideal for radial access. Visit bostonscientific.com or contact your local sales representative for more information on the TruSelect microcatheter and to learn what it can do for you. I'm Sabeen Dhand in IR in LA, and I'd like to welcome back another interventional radiologist, Dr. Don Garbett from Radiology Associates in Eugene, Oregon. Welcome back, Don.
Thanks, Sabeen. Thanks for inviting me to chat with you.
Of course. I really enjoyed your prior episode on acute limb ischemia. It's episode 118 for our listeners to know. But, I not only did I learn some tips, but I saw a lot of similarities between both our practices, especially how we handle vascular. We're going to switch gears and talk about something way more bread and butter. I mean, it's pretty much any hospital-based IR practice, provides services for GI bleeds. And so like anything IR, there's a million ways to skin a cat. So I want to know, and I want to compare, how our practices both handle this. So yeah, how in your practice, how do you approach or work up a GI bleed?
Yeah. I think we do a lot of GI bleed. I think most people in our field do at this point. I think, our approach is, and I think it's developed over the years. Like, in training, we were sort of, and I came out of training in 2015. It was sort of changing. We used to just bring everybody to angio and then check every artery, shoot all three, SMA, IMA, celiac. These days, we just tend to get a GI bleed, CTA, for most patients. And that's whether they're inpatient, on a regular floor, or if they're ICU, or if they've just been scoped. We'll still generally get the CTA just so we have a roadmap. And we'll do not the regular CTA, we'll do the, non-con CTA, venous, delay.
Triple phase, the little triple phase to see the bleed, right?
Yeah. And we taught our CT techs that if it says GI bleed and it's an inpatient, just that's what you're doing. So if the hospitalist ends up ordering it already gets changed.
Okay.
Which is nice. Okay.
I like that. The fact, I'm glad you brought that up because there's a lot of stuff, people talking about doing CTAs, really not even taking to angio unless you get a CTA. So would you say, are you guys pretty hard and fast? Would you always get the CTA or would you go to angio directly on these patients?
I'd say it's rare to bypass, but we still do. I think the default is to get the CTA and someone calls and says, the hemoglobin has dropped. There was some bright red blood a few hours ago.
Yep.
We're getting a CTA. But I've definitely got ICU calls at like midnight and where they haven't had any imaging and they'll just say, we have a profuse bleed. We're crashing. And I'll just say, send them down and I'll be there I can get there in 8 minutes in the middle of the night. So
Nice.
we'll go fast. And I'll just
that's
go.
pretty awesome.
Yeah.
Yeah, that's awesome. You live that close to work, huh?
Well, Eugene's small, no traffic. Driving at nighttime speed, I can get there pretty fast.
Faster than they can even bring down the patient.
Yeah, the techs aren't even there yet. Like, I'm opening the pack.
That's awesome. No, so, okay, even before CTA, what are you, it's funny because I think there's been a shift of workups on GI bleeds. I mean, our GI docs always, back in when we were training, we basically graduated, we finished the same year. So we're totally the same year. I remember in training and be like, GI has to scope the patient. Is that happening 100% of the time in your practice now?
I think it is a lot. I think it is probably 90% of the time, because almost every patient we get called on, GI scoped, they can't find it, or they found it and can't get to it. It's one of those. But
we sometimes get this weird, like if it's a lower GI, bright red blood per rectum, sometimes our GIs, and maybe this is just my practice in my hospital, they'll be like, there's going to be too much blood in the colon. Like, we're not even going to take them. So, and that might be time of day dependent, but you know what? I basically just say, F it, like, fine, I'll just take it. I don't know if that's something that happens in Eugene.
That's an interesting. So Sabeen, remind me, are you at a university? I don't remember. Or are you?
No, I'm at a private practice.
Okay.
My hospital, it's we have like 3 hospitals, but it's a community, private practice.
Okay. So it's similar.
Yeah.
I think it may just be the GI situation. Maybe they're just overconfident, or I shouldn't say overconfident. Maybe they're just very confident. They will go in.
Yeah, that's awesome. That's great. That's
like, I've walked in to consent and they're in there scoping already.
That's awesome. That's great. And I wonder, when they do scope, how often do they find, like in a lower GI bleed that's profusely bleeding, do they give you that final answer as far as like, oh, there's too much blood? Or do they find it a lot?
No, we'll hear that. We'll definitely hear that.
Yeah.
I feel like they still, I don't know their percentages, their success rates, but they still seem to do it. So I wonder.
Yeah.
But they're high level. They're all doing ERCP. Some of them do like really advanced ERCP.
That's awesome.
So I think they're just coming from, I feel like we're on the same page. Like I feel like we're doing really advanced stuff, and I feel like they are too.
That's great.
So we're all battling for who's got the best skills.
I think, GI and IR work so close together. I think we have a varied different group between our 3 hospitals. We have some that are really good and some that are on the other side. Having a really good relationship with any IR practice. I mean, you talked about building a IR practice in rural. I mean, having a GI group is really vital, I think, to doing these bread and butter procedures. So, okay, we talked about getting a CTA. You get it most of the time, us too. Now there's a school of thought that if the CTA is negative, you do not take to angio. Is that what you do, or do you go to angio still?
Well, yeah. Well, in general, not go to angio if it's negative. There's very few exceptions. If the scope was negative, if the CT was negative, but GI has really identified an abnormal area, then in that case, we'll still take them, and maybe empirically take something.
And that's pretty cool. So that's a good point. Like if they find, some sort of lesion, but it's not necessarily seen on CTA, would you just empirically embolize where you like give an example of what you would empirically embolize?
Yeah, I think we see a lot of duodenal ulcers.
So that GDA embo, right? That GDA sweep kind of embo. Yeah, those are kind of fun. It's like, you're going to go, I think those are the ones I know exactly what you're talking about. You have that duodenal, there's ulcers that are bleeding slowly. Like, okay, I'm just going to go and embolize the gastroepiploic and GDA.
Yeah. Right? And it's, you're in and done, and you're not hunting. You just go.
Yeah. I mean, so why don't we talk about technique? I mean, you did, so say you're taking him to angio. You talked about shooting the celiac, SMA, IMA. Generally, you're going transfemoral. Do you do any transradial now?
So I didn't think we'd talk about that. So I do so much radial now that it's almost easier for me. Yeah. And then especially if any of them, if they're, I guess not aspirin, we don't worry about that. But if they're on anticoagulants, what they could be, they're usually off by then because they're bleeding. But if
usually it's stopped.
If they're even like a bit heavy, where I don't want to deal with the groin, I'll just go radial, and my techs already know everything. I have like a list. They just open up the list.
It's great. It's great to have that, right? I mean, in our practice too, we go radial for a lot of things. GI bleeds is kind of, I would still say majority is femoral in our group, but we have been doing more transradial, especially that, we have longer microcatheters. I mean, we got from femoral, I usually use like a 130 length microcatheter, just in case I got to go distal in the SMA. From radial, are you using like the super long, like the True Selects, the 175?
I'll have it ready. If they're tall, I'll just go straight True Select, and they got the burn shape on that too, which is nice.
Yeah, you like the shaped microcatheters and stuff. We generally we like pretty much just use straight and curve our wire. But do you like the curved shapes?
I did. I didn't care for them initially, and now I've noticed, and maybe I saw somebody do it, but you can just put that little 3cc syringe on the back, and I can almost just drive those.
That's awesome.
Yeah, without the wire sometimes.
I gotta try to see another little tip and trick. I love this stuff. So you just drive it. That's, I think, what the direction was meant to be, right? They kind of designed it to be a kind of a microcatheter without a wire. Yeah, and using so are you coiling generally for these if you see a positive bleed? Any other kind of embolic that you're using?
I did use glue years ago. I think it's just so easy to do the coils now that I've veered away from it.
Yeah,
I did used to do it before, but I think I'll grab, depending where it is, I'll grab a detachable, and then I'll shove a few cook coils behind it. Just, I hate when they don't occlude immediately.
Yeah. It's so true, right? Especially, sometimes the rubies, because they don't have any fibers, sometimes it doesn't occlude immediately, right? So you're like injecting, and you're selectively injecting, and you still see it. You're like, is this going to eventually block off or what? And you just throw some kind of fibered coil, whether, the cook ones are nice, but I've been loving detachables. I'm not going to lie. It's so much more control.
Oh, especially for that
expensive.
First coil. It is expensive. Well, that's why I'll put the cook behind them.
Have you had any issues using, if you're using a lantern, which is a little bit bigger of a catheter, you have any issues pushing a pushable, or using a typical ONA coil, like, I don't know, interlock or any other ones?
I'll mostly use the detachables, and then the pushables.
Yeah.
The pushables, I'll just inject them.
Oh yeah.
Yeah.
There's nothing better than just
love it.
Pushing them in. And then why'd you move away from liquid? Why'd you move away from glue?
Yeah, why did I move away? I guess it's just, you gotta, I'm scrubbed in, and then I've got to like tell the tech what to do. And I get a lot of new techs. Like, there's a lot of turnover, and
interesting.
I'd have to be training all the time.
Yeah. Yeah, it is. I mean, it's peculiar, right? You have to get everything kind of, D5 and all of this, keep everything clean. And whereas you can just get a coil really quickly. That's a good point.
Yeah. I think if I had, steady techs, we do neuro too. And if the techs were if I always had the neuro tech, I'd be like, yeah, let's do it. I don't know.
Let's do it.
But it's easy. The coils are easy enough with the detachables that I don't worry so much.
Yeah. Yeah. And what about, have you ever used like onyx or anything like that? We've been trying lava, in our trial, which is basically onyx. But have you tried onyx?
I haven't
in these kinds of in GI bleeds.
I haven't for GI bleeds. I've vascular mouths, but I haven't used it for GI bleeds. That's cool.
Yeah.
Okay.
Yeah. Again, you bring up a good point though. I mean, it takes this training.
Yeah.
I mean, you gotta mix it, draw it, and all that, and it's a lot damn easier to just throw in a coil and be done.
Yeah, it's like open,
especially at night.
It's lava. Is that another company? I'm not familiar with it. What is that?
Lava is basically onyx for peripheral. And they're it's very similar to onyx, and they're trialing it basically as a peripherally indicated liquid embolic, but it's basically onyx. So they're undergoing trials right now. Speaking of embolizing, then you ever use particles? What about particles?
Is there a case? I'm trying to think of a situation in GI bleed.
I personally don't.
I don't think so.
You know, sometimes I've used a little gel foam again to get a little occlusion,
I'll do that too.
because I just, like a little sandwich, a little gel foam, especially on the GDA thing.
Yeah.
But I haven't used particles, although I've seen some talk about it, but I personally have.
Yeah, I've done the gel foam thing, but I haven't done particles and GI bleed.
So coils, pretty much your go-to. You're transradial. You're coiling usually through a microcatheter. Are you going, so on a negative, you've shot your celiac, SMA, and IMA, it's negative so far. Are you then selecting out branches? Or are you just staying in those three?
That's a good one.
Or it depends on your mood.
It can. Well, hopefully they have some clips somewhere from before, and then you might think, oh, maybe they rebled at some old spot. So then I might coil something like that. But I will go select stuff.
Yeah.
I see nothing, and I shot the main vessels. I'll go shoot the GDA, and I'll bring it down deep and shoot, and then I'll go back to SMA, and I'll pick one or two branches going off to the right usually.
Okay, like ileocolic and middle or something.
Yeah, I'll probably sub-select 3 or 4 vessels total.
Okay,
I know. I remember in training, like you shot 3 vessels, negative, done. I just if it's coming back to me the next day, I'm trying to get it. We're trying to get it done.
Yeah, exactly. You're just trying to get it. Is there any tricks? I mean, some people, I one time read, I think it was on the SIR forum, that some people are using CO2.
Oh,
I don't personally.
I haven't.
And then some people are either like doing a lot of saline flushes or diluting their contrast a bit because they say that the contrast is too thick and might be, as if it's thinner, you'll be more sensitive to GI bleeds. Have you heard of any of that or do any of that?
That's interesting.
I don't.
I think our contrast, if we're doing power injections, it's already diluted 60.
Oh, you do say, okay.
But so I don't dilute more.
Yeah.
But I wonder I don't know the dilutions. What are people, do you know how much they're diluting?
I don't know. I just remember reading it one time and I thought that was interesting.
That is.
We do 100% on ours. For peripheral angios, we'll dilute ours, but you don't find that it decreases like your visual, like on a big person. If you're diluted, are you seeing all the vessels pretty good? That's my worry.
I'll turn up the juice on the fluoro as soon as I can't see a catheter. If the catheter's like see-through, we're turning the juice up.
Yeah.
So it's usually not an issue. We have a brand new, our angio suite is 1 year old,
Oh, for
the
real?
fanciest Philips.
Nice.
So we can see pretty well.
Oh, nice. That's good. That's good. We're working with like it in our main lab. We have like 2 Siemens labs, but they're like 10, 15 years old. So they need an upgrade.
They need an upgrade. The new Siemens ones are really great.
Yeah, we're looking into those. Those look real nice,
We went from a 14-year-old suite that I couldn't see anything. Triple mag all the way, fluoro rate at max, 1 gray per minute. I couldn't see anything.
And now it's like life-changing, right?
Yeah. It's so different.
What about, it's something that our group has worked a lot on, I kind of picked up this technique from training, is provocative angiograms.
Yeah.
I
was thinking you're going to ask that.
Yeah. So let's talk about that. Are you doing them, by the way? And then what type of patients are you taking?
Yeah. I think it's certainly not a normal in our practice. So we don't have a protocol or anything written up. And then I'd say it's pretty rare. So that's step 2. It's pretty rare that we get one that's negative. But in that case, I'll do the hunt. And then I will, because we keep 4 TPA in the fridge in the room. I will get that. And I know people are doing like big infusions. I've heard this. I'll inject 4 TPA in the SMA and then reshoot a big
SMA.
One. Yeah. But I haven't done anything more than that.
Yeah. That's right. Because I like the way how you guys have organized your workup. Basically, if the CTA is negative, you're generally not doing an angio, right? Our practice is kind of mixed. If it's, and it might be time of day dependent. All right. If it's like 4:30 PM, and the CT is kind of backed up, it's like, all right, just bring them in quick. We'll boom, So we actually have a little bit more than I like of a negative angio rate. We frequently will take them, but we also take negative CTAs to angio, and every once in a while they're positive. So, we haven't come up with a really hard and fast rule in our group. Everyone's a little different. So yeah, we've had these like kind of negatives that we do provocatives on quite often, and it's pretty amazing. I mean, yeah, you've seen it work, right?
Yeah.
In the form, even just with 4 milligrams of TPA, I'm sure.
Yeah, we have.
So and so it's pretty well controlled. I think people were really kind of scared about it before, and like, oh my God, you're injecting TPA in a bleeder. Like, it just sounds like cowboyish as an IR is, right? But we've liked the results that we've gotten so far. And yeah, we're kind of one of the crazy ones who'll do big infusions, like 50 milligrams.
50? Is that what you do?
Yeah.
Holy cow.
That's our upper limit. Yeah. But we'll get some people. It'll be like, a year or two of just these intermittent bleeds, and they've been getting chronic transfusions. No one can find it, and yada yada yada. So we'll do those, and in a good half of them, we'll find something.
Oh, that's really interesting.
So yeah.
And what do you, so
something.
How do you do it? Are you just parking a catheter in the SMA, or what are you doing?
Yeah. It's either SMA or IMA majority of the time. If it's sometimes it'll be a left colon bleed, so then we'll do the IMA, and yeah, we're just parking there, and then every 5 minutes we're injecting another 5 milligrams of TPA. We'll give some heparin and nitro as well, and yeah, it takes a lot of contrast, and we'll do them with anesthesia. And do you do how's anesthesia availability in Eugene?
So it varies. We do stroke, and they automatically come for that, right? So they're
Okay.
part of that.
So your stroke, you guys are doing all strokes with GA or with anesthesia?
With anesthesia, not always GA.
Yeah, that's good.
But it's not a automatic for GI bleeding.
Yeah,
We're just
I think
trying
most
to get them in fast.
Yeah. You don't want any slowdowns and stuff too. So agree. I mean, ours are mostly constant sedation. Are you? Sometimes one trick I do too, I've totally forgot. Sometimes I use glucagon. Have you ever tried that?
That's a great idea.
You can stop. It literally stops small bowel, like the peristalsis. Like it just, but it only lasts for like 3 minutes.
Yeah. I guess if you had a crazy bowel moving all over, it'd be great. Yeah.
Sometimes, I don't know. Some of our patients are real gassy, I guess.
Yeah.
I don't know.
Yeah.
So,
Or if they had a recent scope, they're going to be all insufflated.
yeah, exactly. So yeah, it's cool. I mean, we just use like 1 milligram. Try it out. It's pretty cool. It works, but again, it works for like 3 minutes and then it goes away. And I don't know the upper limit, but I haven't done more than 2 milligrams of IV glucagon.
I'll definitely try that next time I have that, one of those.
Yeah. Any other kind of words of wisdom on GI bleeds that you've kind of learned? I mean, again, it's a bread and butter procedure, but you ask all these people, I mean, the way how your practice deals with it is different than how our practice. I mean, I feel like we lack a little bit of guidelines in my practice, but you guys are it seems more kind of uniform.
We've been pretty cohesive about it.
Yeah. Anything that you've kind of learned after training that's kind of helped you with these cases, whether it's been the ones that you select to come down or the ones or after post management, anything else that you kind of recommend?
I think probably two things. One thing is the tech setup. So they've built, might be a little funny, they build a moat around the patient. For the one.
What you're going to have to submit a picture of this at some point so we can put it on our website. What do you mean? I have a moat sometimes when we do like a Plurix catheter, because that ascites or effusion is just going to jump at you. Is that what you mean? Like a little like towel, I don't know, wall?
Kind of, yeah. They take the blankets all the way around the patient.
Okay.
Like, but just below the butt and then up to the shoulders. And they build like a capture for the blood. Because sometimes, if we get a crashing one, it is a huge mess. And yeah.
This is
one of the techs came up with this years ago, I guess.
That's really, you have to share this.
I'll have to get
whether it's on your socials, on Twitter or something, obviously not with the patient there or something, but That's pretty interesting. Yeah, it can get messy, like a literally like a horror show, like especially GI like lowers, maybe it gets kind of hunted under the blue towel, but like an upper, and then they're like a horror show. It can be really, really bad.
Yeah. One other interesting thing that happened one time, it was an accident. We were doing an upper GI bleed. It was like a fundal. It was a fundal. So it was like quick left gastric catheterization. You can see all the clips, and I shot the pick. Everything spasmed. Couldn't get in.
Oh yeah. So everything's a spasm.
It's all spasm.
They're bleeding.
But you can still see it going. It's not occluded.
Okay.
And then I thought I called out nitro. I was like, I need nitro. But I think I said epi. They put epi on the table in a syringe, and I assume it's nitro, and then I inject.
You just slam it in, yeah.
I slammed it right in, and it goes. Nothing happened to the patient, but the whole left gastric just occluded immediately.
Wow.
And I looked at it, and I was like, "Are we done? Is that because GI injects epi?"
Yeah. No, apparently that's how they would also treat GI bleeds in the past too. They would drip vasopressin.
Oh yeah.
And like this is back in the day,
Right.
and they would just drip vasopressin in the SMA or something. I don't know, for like in the ICU. That was one of the ways they would treat it. So that's great. So then did the bleed stop, or did it come back?
No, it stopped. It stopped, but and you couldn't see any more active bleed. But I had a little bit more vessel, so I just punched one coil into it and called it good. And they never rebled. So, but that was that's a anecdote.
Yeah. Speaking of the left gastric, I find that vessel, you can do whatever you want to it. You can slam, like you can do particles there, right? I mean, that's what they do for bariatric embo. You can throw gel foam. Like if you're suspecting a left gastric bleed, you can just like take out that vessel, and there's like no, I don't know, for knock on wood, there's been no badness. I mean, have you seen gut ischemia in any of your embolizations? I personally have not. It's just such a robust organ system. But have you had any ischemia?
I haven't. I've heard stories, but I haven't had any. I haven't seen any.
I mean, whether you go really selective, or I remember one or two cases early in my career I couldn't get into, and I had to embolize the marginal artery a little bit, and that still was okay.
Oh,
wow.
So
I mean, I don't know. I don't know, but luckily, it's just such a robustly collaterally flowed system that I don't understand why not ischemia, but it's great.
Yeah, I think it's helpful for us.
Great. Well, the one last question I got for you, Don, is, and this might not be just for GI bleeds, but as our listeners probably don't know, that you have really damn good taste in music. So what is, you're going in, you're getting pumped up for an angio, whether it's GI bleed, what's your music choice to get you really in the zone?
So I'm an EDM fan, and so one of my techs has really fantastic taste in music, and if she's there, she'll just do it. She'll just put it on, and she has great taste, and I just love it. But if not, I have a playlist that's like my go-to, and it just spans like everything in EDM that I've liked for the last 10 years. It's one list, and it just goes on.
It's so important. Yeah. It's, I can't work without music, so I always have it on. And although some of my techs call my EDM Roomba music, it's, it's fun. I try to play the chill stuff, but yeah, it's great. I mean, it's great to talk about these bleeds. I mean, everyone coming out of training programs learns how to do, how to approach these. And it's important for our listeners to know that there's a lot of ways to approach them. Whether you coil, whether you glue, looks like you're doing all of them trans-radial, which is awesome.
Well, I'll caveat, if it's the crash, if they're the crashing GI bleed, I'll go groin, just because it's easier for the text to set up.
Yeah. True. It's just So, and I think, I don't know what's on the frontier as far as GI bleeds. I'm sure GI, it would be really interesting to talk to them one day and see, what's new for them. I mean, are they doing anything new, or is that just kind of a, hey, there's been no development? I don't know, but it's something that will stick with all of us. It's something that's a great way to help patients. and really stop bleeds. It's pretty amazing when you see like a hypotensive crashing bleeder and boom, you embolize, and literally by the time they're getting out of the room, they've been stabilized. There's something, great about that.
It's funny because we'll get the coils. You see the active bleed, you put the coils in and you occlude it. And I'm sure you've seen it where it's just the tachycardia stops and it's like almost instant. It's deceiving how quickly it is.
Yeah, it's pretty addictive. I mean, I think that's probably something that when I saw it the first time, probably in training, I was like, this is really, I mean, it draws me. That one of my favorite things is to embolize an IR. I think if I'm not recanting a vessel, right. I just still love that little youthful part of just, hey, I'm going to embolize this like a GDA embol. I'm like, this is great. I'm just going to embolize this, like make it look nice, go up to the origin. Just, I don't know, just kind of have fun with it almost,
There's, I just want to share one good case because it was just a dramatic one.
Absolutely.
So I think I'm at our smaller hospital and I'm doing some biopsy or something. And I get a call from the ER. The GI is in the ER with the scope in. Okay.
Dang.
And they're just,
your GIs are great.
They're so good in the ER scoping. And he's got the scope aimed at the duodenum, at a duodenal ulcer. And he's just suctioning because there's so much profuse bleeding that it's like airway compromise. So he's just suctioning. And he said, well, I guess he told the ER doc, see if IR is available because I can keep doing this until they're out of blood.
Yeah. Oh, man. Oh.
So somebody grabbed me, like they literally came over. I was doing a lung biopsy and I just like finished. And they're like, just come over. And I came over and I look on the screen and he's like, there's the ulcer. He points at it. And he says, how soon can we get you in? Or how soon can you get the patient in? And so we went like rapid fire. I just ran over to the cath lab. It was empty. It happened to be empty that minute.
Perfect. It's fate.
Yeah.
It's fate.
So we just ran everything with the scope in. He's
with the scope in.
He kept it in just suctioning at the ulcer. We get to the cath lab. The surgeon is right there as well because he's ready to open. Whoa. And it's like all of us, and we're all in there. We get him on the table, starts coding, like immediately starts coding. Of course.
Like, there's fully fine in the ER, suctioning units of blood, but then
so, and we've got like we've got 3 nurses or 4 nurses. We got an ER doc, we got surgeon,
this is the whole team.
It's everybody.
I mean,
so we're doing, I hurry up and just get access, no imaging, just the old school betadine, no drapes, nothing, no drapes. We're just like,
okay, this is legit.
I'm just like, we're going on sterile. Don't worry about anything.
Yeah. We're just saving this person's life right now. Yeah.
These are the fun moments when you have a med student and they're like, I want to do IR now.
Yeah.
So they're literally doing chest compressions. We get access. I'm, guys, are you cool just getting x-rayed? And they say yes. Yeah. And we just shove the catheter up. We already know where it is. So I just shove it into the GDA pretty much without imaging. It just caught it. I saw it go over. I'm like, I guess we're in. I inject a little bit of dye and you just see the waterfall of
I'm guessing there's like you use a Cobra to go on the celiac. Yeah, I love it because then it'll just go to that. Yeah,
it drops.
Like, boom.
And then just drop the kitchen sink, every coil, boom, 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 boom. And he suddenly got his rhythm all back. It was just wild.
Dude.
It was one of those. And at the end, there was blood all over the room. The whole room was full of blood.
I see why the moats come into handy there now. Yeah. Oh, that's insane. So, I mean, I have to say that probably that adds that's adrenaline and having a good outcome. It's just, it's something that's great. That's crazy story.
And it was, it's the visual. We had general surgeon is on top of the patient doing compressions. GI still has the scope in while we're doing it. Like the whole thing, it was pretty wild.
Yeah. I bet you made a lot of friends with different services that
we did.
It's like, oh man. Yeah. That's a total win for your service right there.
Yeah.
Great. I mean, what's up?
I was just wondering, do you want to talk about, I mean, I know it's a whole other topic, but you do the triple phase and then you see like there's varices and it's not arterial.
That's a good one. That's happened to you. That's a really, really good point.
Yeah.
And then that's something really important to mention. Yeah, we have to talk about that, where not all bleeds are arterial. We've seen, and it's been weird. Sometimes it's not even like a typical cirrhotic or something. Yeah. It's like these weird, like jejunal varices or some nonsense, right? I don't know. They like for some reason have this portosystemic shunt in a non-cirrhotic. I don't know, maybe they were born with it. What do you, I'll tell you what we do once. I want to know what you do for those. We've only had a couple. I can think of a handful, like 5 cases like that.
We're probably the same, like a handful.
Yeah.
So
what do you do?
We'll see, luckily, if you didn't do the imaging, you probably wouldn't know, right?
I have one case where one of my damn smart partners, none of us saw it, but then when you look back, you see it. It was like, you'd carry out the run late. And
no way.
And then he saw these varices on the on the late. I'm just looking for like the SMV, and he saw these things in the corner, and I'm like, holy shit. And he was totally right. So
those are mad props.
But yeah, if you don't do the imaging, aside from that case, you probably wouldn't know and call it negative. So do you go direct portal and embolize them? Do you do a TIPS, or what do you do?
I guess it depends on what you see. If it's a totally cirrhotic liver, I might go to TIPS. But I think these are usually like the surprise, right? Where it's like, there's some weird shunt, there's some weird varices.
Surprise. Yeah.
So, and maybe fatty liver, but not quite cirrhotic. So in those, I'll just stick direct portal and go embolize the varices directly. And then we'll key them in to follow up to see if they need, portal hypertension treatment or something.
More stuff. And aside from those varices, even so, gastric varices, which is an upper GI bleeding issue. In cirrhotics, are you a believer of TIPS? Are you a believer of some sort of retrograde obliteration, or both?
Yeah, I definitely, wasn't it Sabri that was on not that long ago?
Yeah. So exactly.
Yeah, I mean he's the master, and there's a few masters out there.
He's the master. Yeah, exactly.
But I do, with the BRTO, you have a bunch of gastric varices. They're actively bleeding, and you BRTO it in that situation, and you do push out some blood, invariably they're gonna pop.
It's pretty pressurized.
Yeah. So I guess I've done some BRTOs when they've bled recently, but I do expect that they're gonna bleed, and so we're actively replacing fluids and blood.
And would you do a TIPS in those too, or do you just see how the Berto does, or the Berto, Cardo, Pardo?
Right. I think if they're isolated gastric, we've generally gone to Berto.
Yeah, same.
But if there's varices all over, then we'll go to TIPS, as long as they're not like MELD 25.
Yeah, I know.
Or fluid heart failure, then you're kind of hosed.
No, these are great points. I mean, again, GI bleeding can be venous, and we as IRs, we need to be able to approach both of those, and again, the imaging can show all of that. So that's a really good advantage of having that triple phase CT to show you, it might be a cirrhotic. Hopefully they see that in their scope, but sometimes they may not, right? Yeah, those are big topics, but we've talked about Berto and stuff with others. I think that pretty much gets all of GI bleeding. I think, anyone who's listening to this hopefully can just go out there and hopefully don't have a crazy case like you mentioned, but get some of those wins. Those are all just I think every IR has a story somewhat to that degree of embolizing and just creating a win.
Yeah. Do you know, it's just a funny one. Do you know the rule of twos? I learned this from GI.
This sounds really familiar.
It's the rule of twos. It's too sick for me to scope and too stable for me to scope. Call IR. That's the rule of twos.
I like it. That's quite true. No, it does seem to give an awesome GI service, and it's great, and having that. So for our listeners, if you have any questions about GI bleeds or anything like that, feel free to contact any one of us. Both of us are on socials, on Twitter, and we're happy to talk about it. So yeah, Don, thanks for being here, and thanks for your time.
Awesome. Thanks for having me, Sabeen. Great chatting with you.
Yeah, we'll see each other soon, I'm sure.
Yeah, man.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabeen Dhand,
Michael Barraza,
Brian Hartley.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson.
And Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Subi Syed.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
And newsletter by Lauren Fang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.